full mode?
Yes. Yes.
Okay. So my today's topic is middle meningeal artery anatomy and embryological variations. So the middle meningeal artery is one of the largest branches of the external carotid artery and most important dural artery because it supplies more than 2/3 of the cranial dura. So knowledge of the embryological development and its numerous anatomic variations is important for neurovascular interventions. So initially begin with, we shall see the basic embryology of the carotid system, as the embryology of the ICA is well determined, but the embryology for the ECA is not completely understood. However, the ECA is formed by a combination of events that occur, that is outgrowth from vessels, involution of some vessels, and assimilation of pre-existing channels that arise from undifferentiated precursor vessels. So we would see by the timeline at 3 weeks, as we can see, the appearance of 3 pharyngeal pouches occur where the dorsal and ventral aorta is connected. So this is the appearance of the 3rd pharyngeal pouch at 3 weeks. So these are the timeline events from 4 weeks up to 10 weeks. So at 4 weeks, what exactly happens is the first 2 pharyngeal pouches, they regress, but the 3rd pharyngeal pouch forms the ICA. So this is the CCA and the ICA that is formed here. And there is one small outpouching here, that is a ventral pharyngeal artery which persists and which forms a ventral pharyngeal artery, and the first and the 2nd pharyngeal artery which regress, the proximal remnant of it forms the primitive mandibular artery and primitive hyoid artery. So what happens is the first pharyngeal artery, the distal part of it, and the proximal part of the 2nd pharyngeal arch, they form the stapedial and hyoidostapedial artery, basically. So they fuse, and the first pharyngeal artery remnant is a primitive mandibular artery. So this hyoid artery and the stapedial artery at the stapes segment forms a hyoidostapedial segment. So this hyoidostapedial artery has 2 branches. One is the supraorbital and one is the maxillofacial. So this maxillofacial gives rise to 2 branches again. One is maxillary and other is infraorbital. This is at the 4-week stage. So what happens at 6 to 7 weeks is slowly this ventral pharyngeal artery start regressing, and there is a outpouching and sprouting of vessels from the main 3rd arch, which forms the proximal segment of the ECA. So this is the ECA sprout and this is the VPA which is regressing. But some part of the VPA stem and the ECA, they fuse and they form the proximal ECA, definitive ECA. At the same time, what happens is the hyoidostapedial segment which was present before, out of that the proximal part starts regressing and the distal part, that is the stapedial part, starts fusing with the proximal part of the ECA. So here we can see that the distal part of the hyoidostapedial segment forms a distal ECA and the proximal part is formed by the ECA sprouting and the VPA stem. So this fuses, and when this fuses, the 2 branches that were formed, that is maxillofacial and supraorbital, out of that the supraorbital forms 2 branches again. One is middle meningeal artery and one is orbital artery, which supplies the orbit. The major supply of the orbit at this point of time is through the supraorbital branch of the ECA. So at 8 to 10 weeks, what happens is the VPA is completely disappeared and the definitive proximal ECA is formed, which also gives the proximal branches, and the stapedial artery, which was the distal ECA, that fuses in such a way that the maxillofacial artery becomes the internal maxillary artery and the supraorbital part involutes, and this MMA comes as an origin from this maxillofacial artery. So basically maxillofacial becomes the internal maxillary and the MMA arises from it up to the foramen spinosum. And inside the foramens, in the intracranial segment, the same segment which was previously present becomes the intracranial segment of the MMA. And this orbital branch remains. However, the ICA starts sprouting and forms the ophthalmic artery, which later on takes over the major supply of the orbit, and this part regresses slowly. And also the previous remnant of the hyoid artery actually becomes a caroticotympanic artery, and it has anastomosis with the ascending pharyngeal artery branch of the ECA. So there is an anastomosis that is formed here as well. So this is the regressed part. So the same thing again, the third pharyngeal artery forms the CCA stem and then the ICA. This is the ECA proximal part that is formed. These two regress and form the primitive mandibular and hyoid artery. And then here we can see this VPA arising from here and the hyoidostapedial artery that is here. And then these fuse and they form the external carotid artery proper. And then they give rise to the maxillary artery and then the middle meningeal artery that goes ahead. So here they have just shown that what the development of all the arteries, like the CCA coming from the dorsal, CCA coming from the third aortic arch, the ECA coming from the sprout, and the hyoid and the stapedial forming the first and second arch, and this distal stapedial artery forming the distal ECA. So here we can see the ECA along with its branches of superior thyroid, lingual and facial artery, as well as the posterior first branch is the ascending pharyngeal artery, the occipital artery, and the posterior auricular artery. And then it bifurcates as a superficial temporal and the internal maxillary artery, which further divides into, further has a branch with the biggest branch, that is the middle meningeal artery, which we can see here, through which goes through the foramen spinosum and forms the intracranial segment. So DSA projection, we can see the superior thyroid artery going down, then the lingual artery and the facial artery as anterior divisions, then the ascending pharyngeal artery going up, and then the occipital artery and the posterior auricular artery. And the bifurcation is seen. This is the internal maxillary artery and the superficial temporal artery, which the internal maxillary artery, the first part gives rise to middle meningeal artery, which up to the foramen spinosum goes anterior and lateral and forms this curve, which defines it on the DSA. And then the middle meningeal artery, further branches are given in the intracranial segment. So this is where the middle meningeal artery usually originates, in the first part of the internal maxillary artery, and it is the biggest branch. And it also has accessory meningeal artery along with it, which sometimes has a similar origin and sometimes it has a different origins, depending on the superficial and deep origin of the middle meningeal artery, which will come to in the next slides. And the same internal maxillary artery further goes ahead and gives rise to artery of pterygoid canal, the Vedian artery, then the infraorbital branch, which all of this have an anastomosis with the ophthalmic artery as well as the other branches, inferolateral trunk of the ICA, which forms the anastomosis. So this part is important as there can be a dangerous anastomosis between the ECA and ICA branches. So yeah, coming here, these are the potential anastomotic sites. As we can see here, this is the middle meningeal artery going through the foramen spinosum, and this is the accessory meningeal artery going to the foramen ovale. And then there is a Vedian artery coming from the vitreous ICA, and then also forming also MMA giving internal maxillary artery giving a branch to it and going through the Vedian artery, and it also has anastomosis with the ICA. So there is this anastomosis, and then there is an artery to foramen rotundum, then the ICA forming inferolateral trunk and meningo-hypophyseal trunk, and also the ophthalmic artery giving rise to a recurrent meningeal artery. So all these are connected with each other, and if there is an embolization or particle embolism at one place, it can have a severe disastrous consequences, as the embolus can go to any of these areas. So this is also called as the dangerous anastomosis area. So coming to the MMA origin, the classic origin is the first segment of the internal maxillary artery into the infratemporal fossa, just behind the condylar process of the mandible. So it is the largest and the first ascending branch of the IMA, and its origin depends on its course with respect to the external pterygoid muscle. So if it is superficial to it, the MMA and the accessory meningeal artery can have a common origin, and the other branches can have a separate origin. And if it is deep, the MMA and the accessory meningeal artery have distinct origins, and the other branches can share a common trunk. Now coming to the embryological variations that can occur because of the complex development of the middle meningeal artery. So this is the embryological stage, and this is the typical adult pattern, which happens if there is a normal embryological pattern. So as we can see here, the pathways that were regressed previously are actually formed here, and the previously the which were intact are regressed here. So basically the ascending pharyngeal artery going through the superior tympanic artery to the hyodostapedial segment was intact in the embryological stage, which has regressed later, and this ECA sprout has formed, which connects the internal maxillary artery and forms the middle meningeal artery here. And then this middle meningeal artery, here we can see there are some branches coming from the persistent trigeminal artery through the basilar artery, which are regressed in the adult stage. Also, the inferolateral trunk gives rise to meningohypophyseal trunk and inferolateral trunk gives rise to some branches here, and also the cavernous branches which are regressed here. And also the middle meningeal artery further goes and forms a sphenoidal branch, which gives rise to a sphenoid and a lacrimal branch. So these branches form the ophthalmic artery in the embryologic stage and also supply the lacrimal artery. So these two branches are later taken over by the ophthalmic artery formed from the ICA. So any of these which have a regressed can persist and cause a different origin of the middle meningeal artery. And everything depends, if there is an embryological variant, we have to look for the foramen spinosum, whether it is small or large, because if it is small, that means there is an embryological origin of the MMA. And so there is a different branching system, like the ECA is supplying half of the branches, and then the middle meningeal is coming from different origin. So we'll come to that further. So there are some very rare but variants which are present, like one is complete hyostapedial spectrum variant, in which we can see that the embryological hyostapedial segment has not at all regressed, and that is why the ECA sprouting has not happened. So this part remains regressed, and the hyostapedial segment takes over, and even the internal maxillary artery is coming from this area only, and the MMA is also coming through the ICA, as we can see here. And then there is something called partial hyostapedial persistence, in which the proximal ECA is also formed, which supplies the internal maxillary. However, MMA doesn't come from internal maxillary, but it comes through the hyostapedial segment. So in this case, we can see that the foramen spinosum is not well formed. The partial persistence vessel is more commoner as compared to complete variant, which is very, very rare. So as we saw that there are some connections with the basilar arteries, so the trigeminal artery MMA origin variant can also occur when this part is persistent. And there can be a variant in which this ascending pharyngeal artery, so the pharyngotympanostapedial variant is also present. So in all these cases, we can see that whenever the origin of MMA is different from the IMA, the foramen spinosum and that part is regressed. So here also we can see the Vidian origin of the MMA coming from here, and also there can be a cervical ICA origin. So these are the various origins of the MMA that can be seen, as we discussed. IMA is the normal variant. Then there is a basilar artery origin. ICA can have a cavernous ICA origin, a cervical ICA origin, an occipital or distal petrous ICA origin. And there can be a hyostapedial segment persistence, which can be complete or partial. In all these cases, the foramen spinosum is absent. And these are the possible embryological explanations. So another important thing is there can be a possibility that the ophthalmic artery, which is formed from the ICA, takes over and it also forms as the origin of the MMA. and the proximal segment is regressed. So here we can see that ophthalmic origin gives rise to MMA. In the first two pictures, we can see that it forms complete origin of MMA is through the ophthalmic artery. And in the lower part, we can see that only one division. Like here, only the posterior division is formed by the ophthalmic artery, and the anterior division comes through the ECA. So when an ECA injection is done, we can see only the anterior division, and the posterior division is actually coming from the ophthalmic artery. Another very important but rare but very important variant is the MMA supply to orbit. As we discussed that ophthalmic artery is the one which supplies the orbit in an adult stage. However, if that doesn't take place, MMA is supplying the orbit and the ophthalmic artery is not well formed, then there can be two variants. One is meningo-ophthalmic variant and meningo-lacrimal variant. So if there is a meningo-ophthalmic variant, it is more dangerous as it supplies both the branches through the MMA. And meningo-lacrimal variant is the one in which ophthalmic artery supplies the major part of the globe, and only the lacrimal branch is supplied by the MMA. So if meningo-ophthalmic variant is present and if the embolization is done proximally, it can lead to total blindness for the patient. Coming to the course of the MMA, it is the most common branch of the mandibular segment of the first part of the maxillary artery, and originates at a variable distance from ECA and superficial temporal artery. So there are basically three segments: extracranial, that is from the origin up to the foramen spinosum, and as distal this is, the more oblique the course will be. And then once it enters, there is an intraosseous segment within the foramen spinosum, and then there is an intracranial segment in which it goes anteriorly and laterally through over the supratemporal fossa, and this turn is characteristically seen in the DSA for identification of MMA. So this MMA irrigates the cranial dura mater, and via its perforating branches provides blood supply to the periosteum of the inner lamina of the cranial bones. And after entering the fossa, the right angled curve to assume a horizontal course, and then runs forward laterally through the floor of the fossa, middle cranial fossa, dura, and the inner part of the cranial vault, as we can see here. So there are two classifications. One has divided the segments into three intracranial segments: temporobasal, temporoterional, and coronal, by Merland et al. And Martins et al. Has divided it as termination of MMA into anterior and posterior at the terional region. So here we can see this is the terional region where there is a bifurcation into anterior and posterior division, and this can be taken as a temporobasal region, terional region, and the coronal segment. So the coronal segment is the anterior division of the Martins classification. So there are various branches of MMA. The first proximal branches intracranially are the petrosal and cavernous branches. So as we can see here, there is a petrosal branch which courses the petrous apex and supplies the dura, including the Gazerian ganglion, and also the superior part of the tympanic cavity through the facial canal. And then there is an cavernous branch which supplies the lateral wall of the cavernous sinus, and anastomosis with the branches of the inferolateral trunk here, and also the ophthalmic branches. So this anastomosis can, if there is a proximal, if we embolize here before the petrosal branch and the cavernous branch, there is a possibility that it can anastomose and go into the ophthalmic artery and cause blindness to the patient, and also can go behind to the middle ear as well. So this is we need to check these branches and go further, and then only embolize. Then there is another tentorial branch which irrigates the cerebellum tent and may underlie the dural fistulas of the lateral sinus, sometimes irrigating the tumors over there. So proximal MMA risk is facial and GSP and injury as well, as this petrosal branch is a part of the facial nerve arcade as well, and it's not only supplies the facial but also the great superficial petrosal nerve. Then coming to the bifurcation divisions, one is anterior and posterior. So anterior division is the in the dura of the convexity and follows the coronal suture until the bregma, and it has two terminal branches. One is a falcine artery, which anastomosis with branches of the anterior falcine artery, and then there are contralateral branches which cross the midline and they anastomose with the branches of the contralateral MMA. And that is why embolizing on one side can reduce the SDH on both sides, is because there is a contralateral supply, contralateral branches of the MMA. So the anterior division also in the near the terional region gives a medial branch that runs and supplies the anterior part of the temporal fossa, the superior orbital fissure, and also it has anastomosis with the ophthalmic artery via the recurrent meningeal branches. We'll see the picture at the end. So this was the anterior branches. The posterior division supplies the major dura and it gives two important branches. One is petrosquamosal branch, which supplies basal 2/3 of the cerebral artery, and also branches irrigate the lateral sinus fistulas. And then there is a parieto-occipital branch. And this parieto-occipital branch participates in parieto-temporal occipital dura vascularization, transverse sinus, and posterior 2/3 of the tentorium. The branches of the posterior, like the anterior division has anastomosis with the ophthalmic artery, the posterior division has anastomosis with the occipital, ascending pharyngeal, the vertebral artery, so with the posterior circulation. So here we can see the petrosal and the cavernous branch, and then at the terional segment there are two branches, one is parieto-occipital branch and one is petrosquamosal branch. We can again see here the petrosquamosal branch and the parieto-occipital branch. This is the posterior division. And the anterior division, we can see here, it has some anterior falcine arteries and some branches also go contralaterally to supply the other side of them, other hemisphere. So these are the branches, the important branches of the MMA from proximal to distal. And these are the territories involved, and these are mostly all of the branches have some anastomosis with the ICA and with some part with the vertebral artery as well. So coming to the dural territory, there are three meningeal arteries. So one is anterior, posterior, and middle. So anterior artery originates from the anterior ethmoidal artery, and it supplies a very short region on the Galli crest. Posterior meningeal artery comes from the vertebral artery and the pharyngeal arteries and supplies the medial portion of the dura of the posterior fossa. And the MMA is the main dural supply, which has a greater surface of occipital, parietal, frontal, as well as temporal. All regions, almost more than 2/3 of the supply is through the MMA. So there are minor variations that can occur in middle meningeal artery other than the embryological variations. This is the branch variation. So sometimes usually the branch bifurcation occurs at the terion, but sometimes the branch bifurcation can occur extracranially as well. Sometimes accessory meningeal artery and middle meningeal artery can have a common trunk followed by division. So, and the parieto-occipital and the anterior and posterior division can divide before the foramen spinosum as well, which is very rare. Most common variation is when the division occurs at the terional segment or at the origin, just after the intracranial segment is formed. There can be a branch division, as we can see here. So after going through the foramen spinosum, there is a division occurring. So this is an early bifurcation. So mainly the anastomosis is the important part. The dural vascular territory of MMA is in balance with numerous arteries which come from ICA, ECA, as well as from the posterior circulation. So here we can see the three major anastomotic regions are the pre and pericavernous region, the frontomedial region, and the posterior fossa. As we can see here, the cavernous branch having anastomosis with the inferolateral trunk as well as the ophthalmic artery. Here we can see the anterior division having anastomosis with the having branches to the falcine artery as well as having anastomosis here with the ophthalmic anterior ethmoidal artery over here, as well as we can see the petrosal branch having anastomosis here with the ascending pharyngeal artery. petrosquamosal branch having anastomosis with the ascending pharyngeal and occipital artery, and also the parieto-occipital branch having anastomosis with the vertebral artery, branches of the vertebral artery here. So basically it has anastomosis with all the anterior, posterior fossa as well. So the clinical implications in short are like chronic SDH, when the traditional treatment of burr hole evacuation has a high rate of recurrence due to the inflammatory response caused by residual blood, which causes the formation of membranes around the hematoma. So these membranes are stimulated by angiogenic factors due to new angiogenesis, resulting in formation of fragile microcapillaries with a high recurrent risk. So now the endovascular MMA embolization represents the principal blood supply of the bleeding membranes. So its occlusion allows the collection to be resorbed faster. Only thing is we have to be careful about the embryological variations and the branching, the early and the branching, as well as the anastomotic pattern for avoiding the complications. Then meningeal tumors. Middle meningeal artery is a major dural artery. So most cranial meningiomas, they receive its supply. So surgery is the first line for symptomatic meningiomas. However, embolization can be used to reduce the blood supply to limit the blood loss during resection. Also, depending on the location, they can be, we have to see whether the meningioma is supplied by the ICA dural branches, the ECA dural branches, or it's a combination. Usually, the anterior cranial fossa meningiomas are supplied by MMA and anterior falcine artery from the ophthalmic artery. The middle meningiomas are supplied predominantly by MMA and dural branches of petrous and cavernous ICA. And the posterior fossa meningiomas are supplied by the posterior meningeal artery, which is a branch of vertebral artery, and from the ECA branches. So the major benefit is in the middle cranial fossa meningiomas and some of the anterior cranial fossa meningiomas, which have major supply from the MMA. So patients who have these DSA blush after ECA injection, and they can be helped by an MMA embolization for middle cranial fossa and selective cases of anterior cranial fossa lesion. Then dural AVF, transarterial embolization through MMA has been described as a successful option for dural AVF treatment. So the good knowledge and precise anatomy, its variations, anastomosis helps in avoiding complications. So it's a favorable way to perform embolization as it has a long straight course. It facilitates the penetration of onyx. It's quite large diameter. It allows the introduction of catheters, and its large dural territory, which often reaches the dural AV fistula in various locations. Also, MMA is vulnerable to skull damage that results in the development of post-traumatic pseudoaneurysm or epidural bleeding. And other benefits is now they have seen that extracerebral vessels and the MMA are involved in the mechanisms that associate migraine with arterial vasodilatation or neurogenic inflammation, and explain the migraine-associated headache. So these are still in the exploration phase. Okay, thank you.
Deep, any questions?
Hi, Bobby. Very nice presentation.
Thank you, sir.
I think we are doing many subdurals now, and this is becoming a very active area of interest for the interventionists now. And standalone MMA embolizations possibly will give the management of subdurals another extra armamentarium, and doing it without bar holes or craniectomies possibly will also give the interventionist a very strategic role, both for the recollections as well as for primary standalone procedures. So this sort of presentations I was very keen on hearing, because it's been a quite long time, and more and more embolizations in this territory will also mean that we encounter more and more difficult MMS, and the cases where we do not find the typical origin of MMA, those are the vexing ones, where we should actually have a look both at the ICA and also at the posterior circulation. So this was a nice one. Thank you, Bobby, for arranging this webinar. I think at least I have benefited from hearing this anatomic presentation. Thank you.
Thank you, sir.
The anatomy and embryology is extremely complicated, but you simplified it quite a bit, Radhika. So I don't think I have any questions. I still have to absorb a lot of the anatomy and embryology that you discussed here today and chew on it a little bit. But the origin of the ECA and how it arises from the ventral pharyngeal arches, that was quite an interesting part of the talk. So thank you very much.
Thank you.
Any other questions, Jayashankar?
No, sir, nothing in the chat, nothing from me, sir. Sir, any comments? Sir?
Nothing else from my side. Deep, if you're okay, then we can close the talk for today.
Yes, sir. In next session, we can discuss about technical aspect.
Okay, that's great. Yeah, that'll be fantastic. Thank you.
Thank you. Thank you.